So thank you for inviting me, and it's this presentation comes after several discussions, mostly with Nathalie Major, regarding the organization of care management in situation of complexity. And she invited me today because we were in contact through the SPORE initiative for the Bright Child. And we thought that it could be an interest for the collaborative on complex chronic condition to discuss these ideas, which is the use of modern communication technology to improve the life and care of children and youth with complex chronic conditions. And a short title could be e-health platform for managing complexity. I will describe certain aspects which is quite known by everyone. This picture from Anton Miller describing the situation of a young girl with a spina bifida, showing the diversity of all the activities and all the actions in each specific activity and the difficulty to connect them to each other and organize care and organize life efficiently. So it's not an issue of care, it's an issue of life complex within which care becomes complex. And this is another one published by Tammy Dewan, Ea Cohen, recently in 2013. Overall, we could have as many pictures like these ones as we have children and families. Each family is unique and has unique difficulties. But this life complexity in situation where it's different than expected because of any kind of problems at birth or after birth, there are multiple consequences in daily life for mobility, functionality, education, social integration, and medical treatment, all the treatment. So it corresponds to all the activities we could see on the pictures before. And of course, delayed development is an issue. Many activities are dynamic, and there is reinforcement loops, which mean that when something doesn't work in one specific area, it has consequences on the other ones, which makes the situation extremely difficult to understand and of course, difficult to find solution, which is the point here. The loops make the complexity. In fact, it's probably the dynamic aspect of all these elements that makes it complex. At the end, the consequence on the people is a lot of suffering, frustration, isolation, stress, and psychological and interpersonal distress, which goes with the isolation for the child, the family, and the caregivers. So then in this situation, care becomes complex, but it's hard to separate the life from the care. The care is only one element of a complex life. So the complexity aspect is something which is developing, not often defined as a number of care providers or number of activities, number of individuals involved in the activities. Because when you have many parts and disconnected from each other, of course, it becomes complex to manage this situation. But it's important to consider that complexity is not a fixed state. So a situation may become complex because of the combination of factors. So it could go from low complexity to high complexity because of the elements that are interacting with each other become more complex. But complexity may also decrease by doing the reverse, which means organizing the function and the connection and the functioning. complexity and distress are not necessarily associated, which means that some individuals in very complex situations can handle it very well. Other ones may have big trouble with situations that are relatively not complex, given the definition by number of risk factors of complexity. So mostly the definition that we use is more based on the probability of complexity, given the number of actors and the dissociation between the actors by lack of communication. But we are never sure that a complex situation leads to negative life if there is a very good system of management at family level and community level. So the approach I wish to describe is a dynamic approach, showing on this top level on this scale is a probability gradient of complexity from very complex to simple, and with a repetition that complexity is not a fixed and it can change in both directions. And in the same way, we have a gradient of management skills, knowledge, motivation, or all the aspects that could help handling well the complexity. Another gradient of network connection and community involvement, and another one of efficiency with a system that is able to detect rapidly some problems and find solutions quickly as well. And we could add probably another 10 gradients, making that there are solutions to organizing life in situations of complexity that could make it more efficient with less consequences on the family and the child and the other youth. So the medical home model, and thank you for Donna, she sent me the reference to a very interesting website, is certainly the best model which is proposed in situations where medical home is an approach, so it's not a building or a place, and it's built on partnership with clinical specialists, families, community resources, with goals of being accessible, family-centered, continuous, comprehensive, which is the whole person instead of just the disease, coordinated, which is the integration of the elements, compassionate and culturally effective, which is to be very personal, taking into account the specific language barriers, ethnic groups, etc. The problem is that medical home is a very good model. It may work in certain situations. It's not working in many other situations because it's very complex to organize a medical home. So we fall from complexity to complexity in organizing the system. Or it could be too costly if there is the need to cover all the points that define a good medical home system. So the discussion today is about using modern technology to improve the functioning, very much in line of medical home. And there are two important premises for this work. The first one is that we are not doing very well in general, again, with engaging children, youth, families in taking a leadership role for managing life, their life, or the care complexity. And separating care from life regarding complexity does not help much because it's very hard to resolve the issue of care complexity if we don't attack the life complexity of the individuals. And the second premise is that offering the appropriate community support could help them to take this leadership role and be strong in organizing the management of care. So the model is relatively simple on this picture at the bottom of one slide, where it's a combination of two interventions that are integrated. One is aimed at creating motivation, and the other one to offer efficient adapted support. And it is supported by a health platform. And at the end, creating motivation will promote leadership, and offering efficient adapted support will help developing an alliance for healthy life and for therapeutic. In the literature, we find a lot of papers about Therapeutic Alliance as a key factor for bringing people, involving them to become self-managers of their situation. So I didn't put only Therapeutic Alliance because Healthy Life Alliance is also important for them to become self-managers of their own life. And of course, there is a continuous link between the motivated children toward strong leadership in managing their health and developing the alliance with the community of practice, which involves all the key players to support them. So the proposition is the first intervention to boost motivation is to have individualized interventions that are based on personal needs and priorities. These needs are transformed into goals, and the goals are transformed into outcomes. And we talk about personally meaningful outcomes because they come from their needs defined as priority. They can be measured with a system of scaling and discussed over time for strategy adjustment and improvement. In simple way, it's a kind of continuous quality improvement, but at individual level. And the goals also lead to strategic plan, which is how can we get organized using our community to reach the outcomes we wish to reach at the end. So this approach promotes motivation, and the goal aspect is related to a coaching strategy. In coaching, you always start by identifying the goals in order to build the strategies and then equip the individual to make them successful in reaching their goals. The second element is a collaborative support network around the child, youth, and families. Members of the network know the need-based strategic plan defined above, and participatory action research process is in place for learning and adapting toward reaching the personal meaningful outcomes. And everything is led by the child, youth, and families. The participatory action research process helps also developing the alliance, the one that can be therapeutic or life, healthy life alliance. And altogether, it brings the concept, it's supported by the concept of a learning community, because it supposes that over time, this collaborative network will become more efficient. And when you reach the alliance, you have already reached a high level of learning process. So the term that is often used in this context is a wraparound care or a support team that will help them to develop the personalized intervention. And the third component is a key person. That's always a key term, key person, but whose role is really typically coaching for children, youth, and families, and also facilitating the collaborative network functioning. It could be relatives, family members, professionals in the health system or in the coaching system, and other peers, but they all need to have a short training in coaching. So behind this slide is a kind of transition. Is this model is that the understanding that for this type of situations we describe with the two pictures, for improving care and improving life in situation of complexity, there is a recognition that each individual is unique and embarked on a unique pathway that requires a very personal and specific approach with constant adjustment in search of the best response to the changing needs, which is developing new challenges for the family and the youth. And it is by the use of intrinsic capacity that can be reinforced, the care network that could be also reinforced and supported by good communication, and the specific attributes of their unique community environment. And I copied here, which is coming from the Thames Valley Children's Center. We believe people know themselves and their situation best. We believe people want the best for themselves and others. We believe people are unique and deserving of respect. We believe people function best in a supportive environment. We believe people working in partnership can reach goals that cannot be reached alone. And that's what supports this approach, knowing that few of these lines are directly related to coaching. So now I will describe the first intervention, which is individualized intervention. So starting from the personal narrative, the medical history, diagnosis, or the contextual environment, the coaching process starts. Develop a collaborative scenario and identify the needs, transform the needs to goals, and then PMO with scaling. Scaling is useful for the follow-up. And then at follow-up visits to reassess treatment decisions, constructive follow-up for continuous improvement. And when I say treatment decision, it could be any kind of intervention to assess where we are after this first set of intervention. And then like in a PDSA cycle, to start with a new one, modified one, the important aspect is to have a good scaling component that makes the discussion more precise instead of being very vague. And that's useful for organizing the follow-up more efficiently. And we developed with UBC a prototype now, which is functioning at the testing phase for what is called the wellness tracker, that helps to follow the indicators of the personally meaningful outcomes. And this picture, which accessible to many kind of media, is also shared with the caregivers and then can be used for assessing the efficacy of the personalized intervention and then modify some parameters of the strategy. So that's the first element of the technology support. The second element of the technology support is related to TIES. TIES has been developed in BC and has been bought by St. Elizabeth in Ontario in 2014 to enable social networks of caregivers. So it's a not-for-profit organization, and we worked on several projects with TIES very efficiently, and we like working with them. So the goal is to empower people to understand, manage, and own their own healthcare. These slides have been developed by TIES. You know, I asked Paul Olioki, one of my contacts at TIES, to send me a few slides. So it's I developed my presentation without having seen these slides, but they fit extremely well. To address barriers to care, mobilize local capacity, and spread health knowledge tools to fill the gaps. The simple definition is that it's a social network which is secure and confidential for communication. And TIES offers the building of networks that are managed by the child family or by a manager they wish to work with them. The coach could be one person like that. And the third element is what it does. The members of the network can share information, share documents. So there is a central library, share a calendar, send requests, send messages, access common tools and resources. So we cannot describe too much because it will take 1 hour. And I described here how it looks like, where the patients and families are central and managers of a family relative network, a healthcare network with healthcare providers, other patients, families, and friends, for example. And they manage also the communication between the networks and control the information. So they are really empowered by the system. And when you have several families, children involved in this process, you can link them together as well with another network, and in the same way, through TIES. And that gives a PAR, participatory action research, within a network, collaborative network around a specific child family, but also participatory action research among all the members involved. So there is a huge potential for learning in this system. Now I would quote Donna Thompson. I went to Donna's blog and I found it so interesting for so many things, including the leadership that families can play to organize and support other families. So the peer-to-peer support can be part of the coaching, or the coaching could involve the peer-to-peer support. And I'll let you read this statement. It's just from a user of the TIES. And I have other experience in BC of users of TIES, where they use time for Lyme disease. I mean, certain clinicians give TIES almost as a prescription. And instead of prescribing a drug, I prescribe you a network. So the overall approach, I will go quickly. This is the two interventions on the left side. You have some interim outcomes about improving motor functions, abilities, self-confidence, self-esteem, many aspects that make the individual powerful because they can control the big complexity, social skills, social integrations, and the main outcome that we are looking for when we develop this kind of intervention is daily life activities at home, at school, in the community. How to reach the personally meaningful outcomes. Of course, they will have direct impact if reached to what makes complexity. So quality of life, leadership development, self-management development, resilience, abilities, and the alliance as well. The challenges is time with, especially for clinicians, with dollar compensation, at least until it's compensated by the government, which it's not the case. Expertise and know-how, there is a need for training for the coaching aspect. Distributed leadership and power, which is sometimes difficult when the leadership has to shift from the medical system to the individuals. It could be that the collaborative network becomes dysfunctional, so there is need to organize follow-up precisely to prevent that. Poor coaching abilities and very difficult situations that are outside of this kind of management, and the overall cost as well. Although it's relatively low, the app for wellness tracker will wish to finish its development for not-for-profits, so it will be for all of us. And for TIES, at the end of one study, they said that it would cost $10 per month for a family to use the capacity of the TIES. So that's my last slide. It's to open the discussion as a proposition to work together refine the model, test the functions. If you are interested, go set coaching, ties communication networks, wellness tracker, and test the whole model as pilot on 2 to 3 sites. That's the ideas. Thank you.
Great. Thank you for that wonderful presentation, very comprehensive. So as JP mentioned, just a little bit of time for questions, or does anyone have any questions or comments?
Maybe Donna could comment about her experience in this situation?
Sure, that'd be great.
Sure, absolutely. I think, you know, it's so important what you said, JP, about comprehending in a home hospital model in complex care that care cannot be separated from life. So, you know, in a shared calendar on ties, for example, there would be a family picnic on one day and a specialist clinic appointment on another day, so that the care and the life is fully integrated visually and practically as well. I also, I guess I wondered, I'm not sure provincially how billing codes work around using ties. In our particular ties network, our son is an adult, so we have a community general practitioner now rather than a pediatrician, and the complex care team at GEO, which would have hugely benefited our family had it existed when our son was still a child. But in our current use of ties, as I say, our general practitioner is part of our network, and he's able to bill in Ontario for the time that he spends on ties. He uses ties as an efficient virtual filing cabinet for other clinicians. Our written reports on appointments with a neurologist, with various specialists, all of those written records are in the ties network, and he will often refer to them when we're at an appointment with him, or if he simply is wanting to look up Nicholas's history. He has as I say, there's a billing code for that. So I wondered about the other provinces and how that challenge has been met. Does anyone know?
Yes.
Kristen, I'm actually from Ontario, so I have to be honest. I'm unsure how other provinces work with that billing component. Yeah, I'm not sure.
I guess a couple of things, and if I don't know how, but I would to do this. But if I think it might be helpful for people to see our own network and how it works, our own ties network. But I don't know how to share a screen on this program.
Oh, I can, if you bring up whatever it is you want to show.
Okay.
I can give you control and you can show the screen of your computer.
Okay. So I've got the screen up.
Okay. And you'll just have to click a couple of things to be able to, it'll prompt you to download something and then share your screen.
Okay.
So, Donna, I have a question, and maybe JP, while you're doing this, Lisa, is how do you decide and facilitate the inclusion of all the different team members to be part of that circle of care?
Well, I think at first when we were building the ties network and we were encouraging people to use it, we were having difficulty with compliance, people tend to use the communication tools that they're used to using. So they will revert to email or intranet or whatever it is that they normally use to discuss client care. And so for compliance, what I found that we needed to do was put information on ties that people needed to know in order for them to do their job with Nicholas, and not share that information elsewhere. So, for example, when Nicholas was living at home, we had 2 different agencies serving our home. One was a nighttime nursing agency, and the other was a daytime care agency. So we would put our home care workers, including the nursing, rotas of when people would work their shifts in emails. And then we would also put it on ties. We found that when we stopped emailing information, they had to go to ties to find out when they were working with Nicholas. They started using ties in more elaborate ways, that they began to engage in the site. So part of that we found that to be very helpful. We also made sure that the case managers from the various agencies were part of the network, and they would communicate with their workers using ties rather than in their intranet. It was a culture shift for them because they were much more used to in-house communications that excluded families. But obviously, in the case of a home hospital, the communication strategies that don't include family members who are the care guarantors, in fact, and the primary caregivers, there needs to be a closed circle of communication that includes families. So we found that by putting information on ties and not, intentionally not making it available elsewhere, it helped people at first to become just used to using the site to communicate about Nicholas and about his care. So I may have made a mistake when I signed on because I'm using my telephone on GoToMeeting.
Yeah, that's okay.
It is?
It should,
okay.
It should be fine, but there should be something, you should have got a little prompt that says you needed to download something, and then you should be able to show your screen. Is there a little dialog box?
Oh yeah, there we go. Okay, I was looking at the screen I wanted to share rather than. Okay, so add.
It should give you an option to show either a screen or an application.
And okay, I'm not exactly sure. Wait a minute. Calendar. Oh, I don't think I want that. So.
Yeah, so we see your screen now.
Okay, great. So this is Nick's Carrying Ties Network. That's the name of his network. And I guess I'll start just by showing you, this is the care wall, which is a record of everything that occurs on the site. We use this Ties network not to coordinate Nicholas's social life, although part of what's involved with his care is transporting him, for example, organizing transportation to hockey games and things that he wants to do. And Nicholas no longer lives at home. He lives in a provincially funded care facility with funding from the Ministry of Health and the Ministry of Community and Social Services. So our network consists of the executive director of the home where he lives, my sister, Nicholas himself. Most of these people in his network are either family members or they are, I'll just show you the list of the network members. These are night nurses, case managers, daytime workers. These are all the people who work directly with Nicholas to support him. Robert Eaton is our GP, the head of human resources, for example. These are all people who have an impact and a need to know in Nicholas's daily care. So going back to the care wall, some of the information that would be, oh no, okay, sorry, just one sec. Some of the information that would be shared there would be appointment summaries. This was a recent appointment to look at an infected stoma. There was also an infection in Nicholas's eye, which was diagnosed as blepharitis, and a probable yeast infection in his groin. In terms of then a user would look at the shared filing cabinet, we can click on lab results for the stoma, and this is the prescription which was sent from the doctor. This is all done on ties, and there are the lab results. So we are able to see everything at a glance. Some of the other files that would be on this, and you see the lock symbol indicates that these files are private, and there are only select people who have access to view them. My sister, for example, would not see those files there at all. They would not appear on when she views ties, because we do not want to share images that are very private. So there's his stoma. We don't want, that's on a very much a need-to-know basis. So in terms of the calendar, you'll see if there's a dot, it indicates that there is an activity that day. So here we are able to see, for example, there's a dental appointment and cleaning follow-up, and the next day at 2:15 there's a pain pump refill appointment. Whereas on the Saturday, there's a festival that Nicholas might have liked to go to called Bacon Palooza. And that's just that's a festival going on all about bacon, apparently, in Ottawa. And so that's on his agenda. So you can see how it's really a mixture of personal events of interest to Nicholas, because Nicholas is a non-speaking individual, and his workers are working 12-hour shifts, and there needs to be a constant communication amongst his staff to ensure that these important medical information, but also important personal information, gets shared, so that so that the responsibility for communicating that information is not left to the family member who is the primary caregiver. In the old days, that would have been me, and I would have had a whiteboard in Nicholas's room. I would have had sticky notes. I would have been emailing people. I would have been on the phone saying, please don't forget that we have an outing this afternoon or a medical appointment, so don't come home, meet us at the hospital instead. Those kind of information, and all parents of complex care children will tell you that a huge majority, really, of their time is spent communicating those kinds of messages to a large team of people who need to know. If there is a system that allows people to know that kind of information, and there is compliance with the tool, and there is a shared objective, as JP said, where goals turn into outcomes, and everyone has complete buy-in into that process, it's much, much easier for families. We also use the message board, and the TIES messaging is, we try to use this as much as we can instead of emails, and we tend to use this in terms of not the whole network. Although if Nicholas was admitted to hospital, particularly on an emergency basis, I would send a message about that to the entire network. And whereas it's perfectly possible to send messages to one or two or three people on using the message facility within TIES as well. So that's Nicholas's TIES network. In the filing cabinet, I'll just show you, it has many, many files in it, and these are all his clinic appointment summaries and his whole medical history, his care plan, which we update on a regular basis, and so on and so forth. And all of that information is available to everyone in the network, unless it is specifically private and under lock and key, or in the vault, as we call it, with limited access to only those who need to know. Does anyone have any questions?
This is Lisa. I'm just wondering, have you had your family physician, your primary care physician seems to be well bought into this, but has there been reluctance from other sort of healthcare people, or, you know, we've had these discussions for years about personal health records and sort of, people having control over their own health records and information, health information, and some people still seem to have a reluctance, or, you know, not wanting to trust a system, or that, you know, your personal information will be, you know, hacked, or whatever the fears are. Any of that sort of reluctance or pushback from people?
No. Well, at first I would say more of the reluctance came from the healthcare facility where Nicholas lives. Mm-hmm. At the beginning, there was a question about whether the data was going to be stored in Canada.
Yeah.
That was important to clarify that, yes, the data is stored in Canada. But it was more not so much a reluctance as a cultural shift that is difficult for people because there's a culture and a practice in the care home of using their own communication system and in their own intranet. And at first, there would be many times where they would say, well, Nicholas has a neurology appointment. Neurology called his room, and they made an appointment, and it's for next Wednesday at 10 o'clock. You should know that. We posted it. And I said, where did you post it? Well, we posted it on the Rotary home board. Oh, yeah, I forgot. You're not part of that. You have no access to that. And that's when I kept having to correct and reset. And I said, we cannot not use ties because I can't see your communications about Nicholas. And I am his power of attorney. I have to be at his clinic appointments, and I need to know everything about his medical care. So it was a little bit difficult at first. It wasn't an unwillingness. It was more of
practice change piece. Yeah.
A practice change, yeah. And I would say, though, that our GP is quite remarkable as a community doctor in his total buy-in about a collaborative approach to complex care. And I actually asked him at one point, I said, so many doctors have turned us down. They just won't take a complex care patient on their caseload because he's too complex. And I said, why is it that you said yes? And he said, I'm just fine with uncertainty. I'm comfortable with uncertainty. So I always remembered that, and I always remind him that he said that. I give him a hug every time I think of it because it is very unusual to hear a doctor say something like that. In terms of the just the general approach to having healthcare providers engage with ties, it's easier now that St. Eliz bought ties because we were using it to coordinate complex care at home when Nicholas was living at home, when ties was still a private company and not owned by a healthcare provider. So it was a little more difficult then, but we were able to convince people that I was the risk taker in terms of privacy. I was in writing and verbally giving my permission to share this information. I provided evidence of data storage and data security from the company. And as I say now that it is a St. Eliz product, it's much easier to convince people of the data security.
Great. Thanks very much.